Continue. So this is, with thanks again to Don and AmCham Philippines. This is now the second part of the overall outline where I'll give you an actual sample. Obviously, the first part was also a sample, but just the introductory. But I'll give you a sample of the actual material. And so this is actually near the beginning. Introduction to medicine. And one reason why I do something near to the beginning, you might say, well, why doesn't he throw something in about pathology or something of that sort? Is the course really builds on itself. And earlier topics support later topics. And it's a kind of like a unfolding. So I don't just blast things from the beginning. And so I was trying to select what will be the best part. And of course, there's about 800 slides, so I can pick there. I have plenty to choose from, but I thought about it. I said I should do something closer to the beginning because if I pick something near the end, it's just very will be hard to explain all the nuances. And there's a lot of the course that actually repeats and reinforces. So it's not like every slide is a totally new concept. We talked about the dualities in the restrictive and obstructive pulmonary disease. So that duality concept, for example, will be a recurring theme. So this is in the introduction to the medicine, but it's not the very beginning. In the very beginning, I talk about what is medicine, what is a doctor, which maybe seem obvious, but actually there are some nuances. For example, there are differences between physicians who are more medicine oriented and surgeons who are more of the non-medical or surgical specialties. I give a little overview of medical ethics, medical systems, global health trends, and the introduction to the patient falls into two parts. The first part is the history and physical, how doctors approach patients. Why is the history very important? How is the history structured? Doctors are not asking patients questions randomly. There's a real logic, but of course, a really good doctor doesn't really make it seem like it's a textbook. It seems like a relaxed conversation. But if you're ever talking to a doctor, believe me, it's not a relaxed conversation. I mean, they may seem like it's relaxed, but they are like a computer, like a sensor gathering information and making hypotheses and so forth. And of course, the physical exam, has a certain technique and structure and so forth. So what I'll focus on for this sample is the second part of the introduction to the patient, where I talk about diagnosis. Now, everybody knows what a diagnosis means. It's identifying what is the disease. But what I'll talk about in the next few minutes will be more of the nuances of diagnosis. And I believe you'll find that quite fascinating. So we'll talk about diagnosis in the context of treatment and prognosis, which is most important, the role of prevention, the principles of diagnosis, which include different kinds of diagnosis, and example of diagnosis of COVID-19, the concept of what's called a differential diagnosis. We'll apply the differential diagnosis to leg pain. When you see these in the table of contents for each section, when you see these red highlights, those are actual diseases and conditions that will be referenced in there. We talk about laboratory tests, what they show and what they don't show. We talk about the dynamic nature of disease. In other words, disease is not just the diagnosis at one stage. For example, you might have a diagnosis, somebody may have a diagnosis of being infected with COVID, but there's also the diagnosis of severe COVID. So there's a dynamic nature of disease. The disease unfolds over time, and I'll give an example of hepatitis B. Then I'll talk about, in the last part of this section, what is called a patient workup. I personally never really liked that phrase, workup, but it's a very common phrase in medicine, which basically means how do we study a certain constellation of signs and symptoms in order to make the diagnosis. So it would be the history, the physical, what kinds of lab tests, what kinds of radiologic investigations, and we'll finish off with a discussion of jaundice, which is related to yellow skin. Okay, so let's talk a little bit about the wider context. A diagnosis is not something that happens on its own. People don't get diagnosed just because they are curious and want to find out what the disease is. They get diagnosed because, they want to ultimately be treated. So diagnosis is a medical term for determination of a patient's disease from the signs and symptoms as I discussed. It's based on the workup, which would be the history, the physical, examinations, and so forth, and it concerns the current condition of the patient. So then we have the treatment, and then of course we have prognosis. Prognosis is not the same as diagnosis. It's a scientific prediction of what will be the likely development of the patient based on the knowledge of the typical course, the mental, physical status of the patient, the treatment, and many other case-dependent factors. So prognosis integrates a lot of information and it concerns the future development of the patient's condition. So diagnosis is the current and prognosis is the future. So here's a question to the audience. Which is most important, diagnosis, treatment, or prognosis? And you can type your answer if you want. And again, please don't look at this as, testing. This is not, back to school, etc. This is just for the purposes of discussion. Somebody said all three. Of course, all three are important. A lot of people are saying diagnosis. A couple people said prognosis. Somebody says correct diagnosis will lead to correct treatment. That's correct. Yes. Okay. Somebody drew on the thing here, so I'm going to stop the share and start it again. Okay. So which is most important? So I would say most people were thinking diagnosis. Quite a few you said prognosis. Would one of the people that said prognosis want to explain why they said prognosis? Anybody want to venture? So I'll type here, why prognosis? So Marty said you want to know the future with medication or change of behavior. That's related to the answer. Okay, let's just, for the sake of time, continue because I know we have a lot to go. So as all of you know, or many of you know, Hippocrates was the founder of Western medicine. And he established things like acute versus chronic. He established diagnosis, treatment, prognosis. He established endemic, epidemic, all these conceptual frameworks that we take for granted now, which of course we're going to present in the program. He established a lot of those things. And he wrote a book called the Book of Prognostics. And he writes in the beginning, it appears to me a most excellent thing, excuse the sort of old style language, but that's how they wrote back then. It appears to me a most excellent thing for the physician to cultivate prognosis. For by foreseeing and foretelling in the presence of the sick, the present, the past, and the future, notice that integration, they will be more readily believed to be acquainted with the circumstances of the sick. That's from the doctor's side. A really good doctor is one who is able to integrate all that information and actually make a projection into the future. So prognosis is much harder. Now, I'm not saying diagnosis is not important, obviously. Somebody made a note that if you got to have the right diagnosis for the treatment. But prognosis is, very much more difficult. A great doctor will be able to do prognosis. Now, if we look at the patient side of things, prognosis is ultimately the most important thing. If the doctor comes up with a diagnosis, you have non-small cell carcinoma of the lung and it's not adenocarcinoma, and it sounds all very complicated and very smart and all that, but that's meaningless to you as a patient. Small cell carcinoma, adenocarcinoma, what does that mean? And then if he says, well, we're going to use, Taxol with this sort of a special immunotib targeted therapy along with adjuvant radiotherapy here and that, all this kind of treatment, it sounds very complicated. It sounds very impressive, maybe very expensive and all that. But what does that really mean to you? Whether it's adjuvant, whether it's gamma rays, or whether it's X-rays for the radiotherapy, that's not so important. Obviously, getting it right is important. What's important to you as a patient is what will be the impact on your life. How long will you live? How good will you live? What activities can you do? All of these are prognosis. Ultimately, this is what's most important for the patient. I will be talking about this a fair bit during the program because a lot of our medical system is focused on diagnosis and treatment. But as we have new digital technologies and AI and so forth, we are actually going more to prognosis, more to the original value. That's why I write return to prognosis. So these concepts are going to be very important in the near future of medicine. And of course, prevention is very important. Biomedical interventions, behavioral interventions, structural interventions for prevention. So you have this four elements of diagnosis, treatment, prognosis, and prevention. And just focusing on diagnosis is important, but not sufficient. Just focusing on treatment is important, but not sufficient. Prevention needs to also be bigger. And of course, as I mentioned, prognosis, which is often not actually always explicitly addressed, is actually the most important. So the purpose of this is actually to talk about diagnosis. So let's go back, and the abbreviation for diagnosis is often DX. And this is the Edwin Smith papyrus. It was from 1600 BC in ancient Egypt, manual of military surgery, and it outlines some of the basics of diagnosis. So this is a very old concept, of course. But in modern medicine, we have several types of diagnoses. First type of diagnosis, and you may have heard some of these terms, is what's called a clinical diagnosis. This is a diagnosis based on the history and physical. So in the clinic, the doctor does a history and physical. It's a diagnosis that's not based on any lab tests. In fact, one could make a clinical diagnosis of COVID. So, for example, if a patient has a cough and very difficulty breathing, and they were known by history to be exposed to one or more COVID positive people, and then given the progression and you look at their whole history and don't have other conditions and so forth, you could make a clinical diagnosis without the test that they have COVID. That may sound strange and it may not be scientific, it may not seem correct, but clinical diagnosis is very important. So most diseases, in fact, and nearly all psychiatric diseases, by the way, there are not many blood tests or x-rays for mental disorders, are made via clinical diagnosis. So this sort of non-scientific seeming method is actually probably the most important method in medicine. We call that a clinical diagnosis based on the history and physical. Now, I skipped the part about the history and physical, so it may seem a little bit strange what I say, but if you had been in the whole mini MD with that earlier part where we talked about history and physical, it would be very clear what I'm saying. So that's a clinical diagnosis. Then, of course, there's a laboratory diagnosis based on lab tests. And in fact, COVID is almost always diagnosed on the basis of course, a COVID test, a PCR test or whatever. And so many diagnoses are confirmed or refined on the basis of a laboratory diagnosis. And then there are pathologic diagnoses. These are based on a biopsy. We take some tissue from the body and we look under the microscope, etc., and we make a diagnosis on that basis. So some diseases, particularly cancer, for example, can only be confirmed with a pathologic diagnosis. If you have a lump on your breast, that's not cancer, that's a lump on your breast. That's a clinical diagnosis of a breast mass. But to actually make the diagnosis of a cancer, you, of course, as you know, need to take a tissue and put it on the microscope and do that study. So some diseases can only be a pathologic diagnosis. Now, of course, that's changing. There are, methods that might be able to use some type of medical imaging and so forth. So These distinctions can evolve as technology changes. Radiologic diagnosis is a diagnosis based on imaging. So many surgical or localized diseases are confirmed or refined by a radiologic diagnosis. These are the four different kinds of diagnoses. And in fact, one disease can have many different types of diagnoses. So I told you about COVID being clinically diagnosed, of course, laboratory diagnosed. Typically, we don't use pathology for a COVID diagnosis, but as I'll point out very shortly, you do have radiologic diagnosis of COVID. Any questions, comments? The four types of diagnoses, very important concept. So let's look at the diagnosis of COVID. COVID, of course, as everyone knows, is an infectious disease caused by the SARS-CoV-2 coronavirus. It's characterized by fever, cough, dyspnea, majority of cases are mild. It has a certain epidemiology. Deaths mostly in older patients, especially those with pulmonary or cardiovascular comorbidity. All of this we know. So if you remember, in February, there was a huge spike, and most of the cases were in China, by the way, in Wuhan. And there was a huge spike in cases on February 12th. I don't know how many people might remember that from the news story, but it was very interesting. Up until that time, they were doing a laboratory diagnosis. But they realized that more people were dying, that more people had some illness than were somehow captured by the laboratory diagnoses. And they were more limited tests back then and so forth. So what happened is they made the change in diagnostic classification clinically rather than laboratory at this point. So based on the CT scan, so it's actually a combination clinical radiologic diagnosis, they changed the criteria. Now, some people who have not taken the mini MD or who don't have a medical background would say, oh, that's lying, or that's cheating, or there's a conspiracy, or all these sorts of things. And I'm not here to protect the Chinese or whatever. That's not the point. The point is that in medicine, you do have different levels of diagnosis. And there is, not always one perfect way to do it. And so that may change. And so you'll get the change in the statistics. Now, there may have been political reasons. There may have been, other aspects and motivations behind this. But from a medical standpoint, this is not evidence of some sort of evidence tampering or funny business. It is probably, to me, evident of the urgency of the situation, the complexity of the situation, how they can capture the statistics in the best way. Should they rely only on the laboratory diagnosis, or should they expand the definition to include a clinical diagnosis? That's the principle that was involved in what many have regarded as an anomaly, but in terms of medicine, it's not an anomaly at all. So it's actually this interesting, didn't take the mini MD, this New York Times report, or actually this internet report says clinically, but it actually was based on a CT scan and clinical, namely history and physical uh, findings. So it's actually, if we were to be totally correct, and those who have taken this program would understand, it's actually a clinical radiologic diagnosis. So the yellow is a laboratory diagnosis, and what happened in the red is a clinical radiologic diagnosis, a combination of the history, the physical, and the CT scan. CT scan showing the pattern that was typical of adult respiratory distress syndrome in COVID. So another very important concept in diagnosis, extremely important, is that of a differential diagnosis. So often people think of diagnosis as somebody has a symptom, the doctor does a test, and they get out pops a diagnosis. It's not as simple as that. Usually there's a symptom and there is a whole list of diagnoses that are considered. We call this a differential diagnosis. In other words, a whole list so that we can distinguish ultimately the one diagnosis that makes the most sense. So differential diagnostic procedures are used to diagnose or at least eliminate imminently life-threatening conditions. It's also, you may have a sign or a symptom, and you may have several possible diseases account for that, but you also do this list to make sure you don't miss something that could be very dangerous. So you might be familiar with Dr. House, who was this famous fictional diagnostician, and he's in front of the blackboard, in front of the students and other staff members, and here's the differential diagnosis: leukemia, Waldenstrom's macroglobulinemia, aspirin overdose, hypothyroidism. He crosses them out. So we have a list, and then we cross out things based on various tests. And that's the concept of a differential diagnosis. And in this course, we'll talk about that in more detail. This is just an introduction to that concept. So let's look at leg pain, for example. Leg pain is very generic. I mean, it could come from many reasons, right? Of course. So we have a differential diagnosis of leg pain. It could be a spinal cord tumor. It could be Lariche syndrome, which is a blood clot. It could be rheumatoid spondylitis. It could be arterial embolism. It could be metastatic carcinoma. It could be sciatic neuritis. It could be cellulitis, which we talked about earlier. The point is not to memorize this chart. But the point is that if we want to say, oh, could they have a metastatic carcinoma, in other words, a cancer? Well, history. Have you had a diagnosis of cancer before? And if they've had a diagnosis of cancer, the list of diseases, the possibility of a metastatic carcinoma rises in priority on the list. Do they have a fracture? You ask the question, that's the history. Have you been in any recent trauma? Did you fall down? Did you have a car accident, whatever? Again, these seem like obvious questions, but the point is that you have this big possible list, and you isolate which ones are prioritized based on this history. Cellulitis, remember, was that inflammation of the skin. So the skin is very red. So you do physical exam. You look, you see, is the skin red, hot, swollen, tender skin? Then you have a very high probability of cellulitis. Now you might say, well, why do we have to have this big, long list? Because some of you said the important thing is to make the right diagnosis. The best way to make it, I shouldn't say the best way, the easiest way to make a mistake and miss a diagnosis is if you don't have it on your list. If you just focus immediately on what's obvious, then you have a higher chance of missing something. So the mark of a professional doctor, a well-trained doctor, is to generate this big possible list. Not so that they waste time and so that they can impress the other doctors with how smart they are. No, the purpose is for the benefit of the patient, so they make sure they don't miss things. And of course, they cross out, like Dr. House, those things that are highly unlikely and zoom in on those things based on the history and physical that are more likely. So very quickly, there are some basic laboratory tests. There are many different types of laboratory tests. We have what's called the basic metabolic panel, or the Chem7. It's often written like this, with the sodium level, the potassium level, the chloride, the CO2, the blood urea, nitrogen, the creatinine, the glucose. You don't have to memorize these. I'm just showing you. And these are the normal values. That's one type of test. It's basically the blood chemistry. Another type of test is the complete blood count, to count the number of cells in the blood. So that also has various parameters of white blood cells, hemoglobin, platelets, and the hematocrit. And then another type of laboratory test, of course, is the urine analysis. So looking at urine, and there are three components: the gross appearance. Is it cloudy? Is it the large volume? Is it very clear or very dark? It could even be red, bloody, etc. That's the gross appearance. The microscopy is to look for cells and other particles in the urine, and of course the biochemistry to look for glucose, for example, with diabetes, sodium levels, the acid levels, and so forth. Now, all of us say tests are great. You get a test, diagnosis. But tests have false positives, false negatives, and we'll spend some time later in the program in January talking about some of the statistics and what the implications. So this is just an overview. But what the tests don't show is they show, false positives and overuse of some tests. So the tests are not perfect, We know that from COVID, for example, there are false positives, there, which are not so common, but definitely can be false negatives. Think about how a false negative might work. So you have to put the nasal swab in the nose, and you have to get some amount of fluid, and then put that in the vial, and then do the PCR test. Now, if you don't do that fully, as you know, you have to reach back. If you don't pick up enough fluid, then you could then miss the virus and you get a false negative. In other words, the person has the virus, but the test didn't pick that up. Even though the test has all its technical aspects and is based on science, some of the procedural aspects may ensure that there's a non-zero false negative rate. And tests are also overused, and this is because often the history and physical are not emphasized as much. It's much easier to do a test, get paid for a test, do it quickly, forget about it, that sort of thing. So medicine is a much more a holistic approach to the patient, and tests are usually only a part of that equation. And of course, I'm just summarizing some very important concepts that will be highlighted later. We're almost at the break time, so I have two more slides. One, it looks a little bit complicated, and you don't need to know the details at this point. But the point of this is the dynamic nature of disease. In other words, sometimes people think you do a diagnosis and it's a disease, but the disease changes over time. Cancer grows, cancer spreads. There's different types of cancer diagnosis based on the stage, the grading, and so forth. So dynamic nature of disease implies, and Hippocrates taught us this, that disease changes over time. So this is hepatitis B. Hepatitis B, itis refers to inflammation. Hepa refers to liver, so it's liver inflammation, and it's related to the hepatitis B virus. And so you'll see different levels, laboratory tests, remember, of the hepatitis B virus DNA. You'll see different levels of the liver enzymes. ALT is a liver enzyme. So these are going up and down and changing in waves. You'll see the antigen being expressed, and you'll see the antibody being expressed different times. There's been all sorts of controversy about COVID. Are people immune? Do they have antibodies? Do they not? It depends on when you test them. The antibodies don't develop immediately, and they go up and they go down and so forth. So this is the dynamic nature of disease. And so we have different types of chronic hepatitis B: immune tolerant, immune active, immune inactive, reactivated, resolved. You don't need to memorize these different categories. The important concept to remember is that disease is not static. It changes over time. And that implies that it's physical signs, it's laboratory tests, it's radiologic signs. All of these things will change over time for most diseases. So last slide of this section, and then we'll take a short break, and we'll finalize with a little bit more specific discussion about COVID, is the patient workup of jaundice. Jaundice is basically this yellowness of the skin. So I know this is going to sound strange, but I assume, I shouldn't assume, but I would imagine, given my knowledge of epidemiology, that we have 40 participants here. And I would imagine that maybe one, but probably zero of you have this condition of jaundice, this yellowness of the eyes, the yellowness of the skin. And I'm not going to test you, don't worry. This is, no one has to reveal any private, personal, medical situation. But I will assure you that even though probably 0% of you have this condition, which is very dangerous, by the way, I can assure you that 100% of you have seen this color on their bodies before. Anybody know what I'm talking about? So I'm going to type in the chat room. Have you seen this color before on your body? Okay, Sandeep, what do you mean by that? Oh, Sandeep says not on my body. Sandeep Kumar, I know you're gonna think I'm not very nice, but I assure you, you have this color on your body at some point. Sometime in your life, you had this color. I'm 100% positive. Now you might think I'm crazy. That's right. There's Carl Nicholas. Carl Nicholas said, from bruises that are healing. That's exactly right. All of you, as children, whatever, that's how children are. They fall down, they bruise themselves. And that's right. Martin said a lot of babies are yellow at birth, but that's not what I was referring to. But that's very smart, Martin. Thanks for pointing that out. But what I meant was just garden variety bruises. Everybody has fallen down and everybody has had a bruise in their life. 100% guaranteed. Even though I know nothing about you, that's just human nature, right? And you know how a bruise looks. It's kind of dark, purple, and then it kind of gets orangish, yellowish, and it goes through a phase that looks exactly like this. In other words, all of you have had this color in a localized area of your body at some point in your life. But I imagine almost none of you, except for what Marty called the neonatal aspect, which is more common, not 100%, but I'm pretty sure almost none of you have had this color of your whole body. So jaundice is a whole body yellowing of the body. And but it's related to the bruise. Why is it related to the bruise? The bruise comes that way because it's blood that has leaked that is gradually being broken down. And the yellow color comes from the breakdown products of blood, which means that jaundice, this condition that you can see here, is from the breakdown products of blood, which then leads to the question, where is that coming from? Well, the blood in the, you're not bleeding all in your body. This is not a result of a bruise. It's a generalized process. And the blood is specifically the hemoglobin, which is red. Red is hemoglobin. And when that breaks down and gets oxidized, it turns into this yellow, which means that somehow the blood products are spreading around in the body. So if we look at this chart, and I know this is very complicated, so you'll say, oh, this is crazy. I'm not a doctor. Why do I have to know about this? But as you do this mini MD, these kinds of charts will be very important, easy to understand. So you have history, physical examination, and then the laboratory exams. And then you have these three categories. Conjugated bilirubin. Bilirubin is the byproduct of the hemoglobin that's in the laboratory test, and unconjugated bilirubin. So conjugated bilirubin means it's either from the liver or the gallbladder, and unconjugated bilirubin means it's from the blood in general. So what that means, let's go back, is the blood in your body is not there the same from when you were at birth. It's constantly replenishing and being broken down. In fact, the average lifetime of a red blood cell is about 90 days. So the hemoglobin is broken down. It has to go somewhere. It goes into the liver, and then from the liver into the gallbladder, it is the bile that goes into the intestine. And then another form of excess hemoglobin in the body is if the blood itself is being broken down. So that leads to the differential diagnosis, the three possible sources of this yellowing, which is related to basically blood byproducts of the liver, of the gallbladder, or of something related to the blood being broken down, for example, a drug reaction or some sort of genetic condition. So for example, if you find unconjugated bilirubin, but all the liver function tests are normal, then you see that it must be some breakdown of the blood. And the other point to make up is to point out is that you have a workup. This is the workup of jaundice. This is the workup for a hemolytic. Hemolytic means breaking up blood. Anemia. Anemia means low blood levels. So you do another workup to specifically look at what could be causing the blood to prematurely break down, thus, in a sense, causing a whole body bruise, this yellowing of the whole body. So jaundice is this all yellowing of the whole body that's related to the breakdown of blood, similar in biology to the breakdown of blood in a bruise, but this time it's the whole body. And you have to think logically, what is the reasons that the breakdown products of blood would be backing up or building up in the body? The three reasons are the liver problem, the bile duct or gallbladder problem, or the blood is being broken down, too rapidly by some sort of drug reaction or some sort of toxin or something in the blood. So liver, gallbladder, hemolysis, that's the differential diagnosis of jaundice. So we'll take a short 5-minute break here. MC?